It is December 11th, I believe. My watch is right. 2019. And I'm Dr. Ara Deuk, Medical Director, CEO, and founder of Deuk Spine Institute. This morning we're going to be doing a few Deuk laser disc repairs. The first one is a patient who has back pain and right leg pain from herniated discs. Now, he had a fusion done in the past, and that fusion was done at L4-5 and L5-S1. So he's developed what's called adjacent segment disease, which is symptomatic disc degeneration, either above or below, basically next to a fusion or prior surgery at a disc. The discs he's had prior surgery at are L4-5, L5-S1. So now above L4-5, L5-S1 is L2-3 and L3-4, the two discs above, and that's where his pain is coming from and symptoms are coming from. It's quite incredible because on exam the pain localizes to the L2-3, L3-4 disc. You could see on his skin where he's pointing. Sir, Dr. Deuk here, we're going to get started. Are you comfortable? As comfortable as you can be? All right. First thing you're going to feel is my hand on your back, okay? That's my hand. I'm going to give you a little bit of numbing medicine under your skin that's going to make this more comfortable for you, okay? But putting the numbing medicine in is uncomfortable. You're going to feel a little stick and burn. All right, so just be prepared for that, and that will start numbing you up, and then we can proceed with the surgery. All right, so our patient is awake for surgery, and whenever we do a lower back Deuk laser disc repair for a herniated disc, patients are awake for the first 10 minutes, and then we put them to sleep. Is he okay?
Yeah, it's always this nasal pain.
Is there an issue?
Yeah, well, it just gets plugged. It doesn't show.
Is there a better one we could use?
No, just stick with it in your head.
Do you want to have some tape? You want some tape?
You want me to stop or are you good?
No.
All right. All right, sir. So while we do the surgery and you're awake, if you feel pain that's really uncomfortable, you just say, ouch. And I will give you more medicine. I'll give you more comfortable, okay? I just need you to say ouch, but please don't try to get off the table and get away. All right? So lay still and say ouch, and I will take care of it, okay? Deal? All right, when we're ready, I'm going to put you to sleep. You'll count from 1 to 100, and we'll get you to sleep for the rest of the surgery. All right. All right, so at the very beginning, I need to gain access to the disc space, and I could see from the angle of the fluoro, without looking at anything else, I can see that the scoliosis has his spine rotated away from me, which is not uncommon, that it rotates away from the side where the leg pain is the worst. So basically, we're on the right side because the patient has right leg pain, and that means the spine's rotated with the right side going forward. Go ahead and do a shot. Let's see how far off I am. You got to get a little bit better. Okay, there we go. That's pretty good. You can see a massive bone spur there. Let's go lateral, please. So for me, the hardest part of the surgery consistently in the lower back is going to be the access, which is just getting from the outside world to the inside world. So basically, gaining access to the disc space. I'm a little bit higher than I want to be. Numb them. So patients with scoliosis, they really do present unique challenges. All right, so we need to do better with that imaging. I think the pedicles are off at the L3-4. So while we're doing the surgery, I'll be talking to my team mostly, and then I'll talk to the patient a little bit as well. No, I think that is maybe worse, but we also need some of this. It's interesting. It may still be too high. So the first thing you have to do is really position the patient well on the operating table. I think that might be better there, actually. Let's wag it now and see if we can get those pedicles lined up. And once you've got your patient positioned properly, the next thing you have to do is position your fluoro properly. And a lot of times, no, it's the other way. A lot of times that means you have to adjust the fluoroscopy. The fluoro is an x-ray machine, and it basically shoots a beam of x-ray through the patient to look at the spine. That's better. And what you're doing in essence is you're looking for the right place to go, but also you're looking for the right trajectory. Let's drop the table a little bit. Just a tiny bit, actually, 1/4 inch. That's good. Maybe we need to put the fluoro up a little bit. But let's do this. I think the pedicles lined up well, the end plates lined up well. I think the pedicle could be a little better. Let's try some wagging just to see if we can make it better. And what we're looking at is the disc right above the fusion. You all can see the metal down there at the bottom of your screen. There's a cage, there's an anterior plate. And what we're trying to do, I think that may be better, is we're trying to line up the disc space right above the fusion. That's that white, I don't know what it looks like. It's between the bones. It's this white, like a M&M almost. And it's right above the metal. That's what we're targeting. I think that's pretty close. Can you clean it up a little bit? That's good. Let's hold it there. I think our entry point looks good. So you don't know if your entry point is any good until you get the fluoro lined up properly. Okay? And if your fluoro isn't lined up properly, your entry point won't be proper. Shot? So you really got to stop what you're doing, shot, and make sure your fluoro is really as good as you can get it. And a lot of times, shot, you're going to be disappointed no matter what because of the patient's, anatomy. Shot? It's always the patient's anatomy. You should never be disappointed because you have the wrong fluoro machine, because you went cheap and you didn't buy a good fluoro. Shot? That is always a concern, obviously. Shot? So a lot of facilities won't spend the money on a good fluoro. Shot? A good fluoro machine will cost $160,000. Shot? How's he doing? So a lot of hospitals, they won't spend the money on a good fluoro machine. Shot? They like to get, the less expensive ones. Save some money. Shot? But I can tell you, having a really good fluoro is of tantamount importance. Shot? So this is actually supposed to be the easy one, and it's not even easy. Shot? Because the spine is really rotated away from me. Shot? Shot? All right, let's get an AP. So as far as the lateral view, we're really lined up beautifully with the back of the disc. But I felt some bone spurs there, and they're kind of pushing the needle laterally, which is not good. We may have to take a different trajectory. It just depends on how much they're pushing the needle laterally. So I'm doing everything I can. Can you feel anything? Huh?
A little bit.
In your back or in your leg? Lateral. All right, so you can see the disc is open there, and that's not the issue. You got plenty of wideness of the disc, top to bottom. The issue is the bone spur. You see that giant beak? You can see that giant beak on that lateral view? That's a huge bone spur. So I never know if I can get this surgery done until we actually get in the operating room. And I can look at people's x-rays and MRIs and CAT scans all day long, but I can never tell if I can actually get into their disc until I get in the operating room. And that's with a very, very experienced surgeon, very capable surgeon. So it doesn't matter how good you are as a surgeon. You never can tell if you can get in until you get in the operating room. Is there epinephrine in that local?
Yes, sir.
There was, for sure, right?
Yes, sir.
Blood pressure is good?
We went up a little bit on that one.
Oh yeah, let's see if we can get it back down. All right. So, this surgery is pretty relatively bloodless surgery. And the things that make it bloodless are the small incision, but also there are things that we do before surgery that help make it bloodless. And those things include blood pressure management. They include getting the patient off of any anticoagulation or antiplatelet therapy. They include getting the patient off of any herbal medications like ginkgo biloba, fish oil, turmeric, getting the patient off of any non-steroidal anti-inflammatories, aspirin, ibuprofen, Motrin, Aleve, naproxen, BC powder, Goody powder, naproxen, Mobic, prescription anti-inflammatories like Mobic, or what are some of the other ones? No. Prescription anti-inflammatories like Celebrex, etc. So, Labetalol. So really it's about managing the platelet plug clotting process before surgery and making sure patients are able to form a platelet plug or a blood clot. They need to form a platelet plug, period. Otherwise we'll be waiting a long time with them bleeding. So anything that it blocks platelets from doing their job of forming a platelet plug has to be stopped at least 5 days before surgery. And that's all your antiplatelet therapies and all your herbal medication, oils that would affect your platelet plug. And we call it bleeding time. In medicine, it's called bleeding time. So an assessment of a patient's ability to form a platelet plug and stop bleeding is called a bleeding time. The ability to clot blood is the clotting time. So the bleeding time and clotting time are different. The bleeding time relies on platelet function, and the clotting time relies on blood clotting factors, usually vitamin K dependent and vitamin K independent factors. So during the surgery, we minimize bleeding with this Deuk laser disc repair by controlling medical issues such as bleeding time, clotting time, and blood pressure. And then surgically, we manage it during surgery by avoiding hitting any large veins or arteries during the surgery, which is my job, to avoid them, which I don't usually hit them. And then to also manage the blood pressure during surgery. So there's a variety of things that are done to control bleeding from the surgery standpoint. Small incision, we dilate the muscle. I don't cut the muscle, I dilate it, I spread it so it's not injured. Can you guys hear me okay there, Sean?
Yes, we can.
So normally we have literally a few drops of blood, but if the patient has high blood pressure during surgery, they're feeling pain, they're anxious, or just your blood pressure's going up for whatever reason, you know, then we can actually get more bleeding than normal. But still, the worst case scenario we get is about 10 milliliters of bleeding. That's it? 10 milliliters of bleeding is nothing for surgery. I mean, you lose more blood doing a gallbladder surgery. Shot? All right, so one of the reasons we broadcast live is that you can ask questions, the audience, the patient, the staff, the anesthesiologist. Whoever has a question can ask it, and we can answer it, hopefully, as long as it's answerable. Shot? 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 We also broadcast live, so is that our best? Yeah. Pedicles lined up good. At the level above. It looks pretty good. Coming in a little lower than I want to be. Shot? You okay? Shot? Where did you feel the shock? How far down? Mid-thigh. All right, that's important. So a mid-thigh shock could still be, at this level, a nerve. Is it better? Uh-huh. And it could also be the facet joint. Shot? All right, so anything? Huh? Shot? All is quiet on the western front? No, I don't like that. Shot? Let's go AP. Only to be. There's a listhesis here that you can all see, where the vertebral body above the needle I'm placing is slipping backwards. Yeah, we're way too far lateral. You have the lateral view? That's it? Yeah. Yeah, it's a big bone spur deflecting me. You feel anything there? Shot? Pain, okay. Pain in your back? Shot? All right, let me see what I can do here. So we're doing 2, 3, 3, 4. Shot? Where do you feel that? In your back? Shot? In your back, right? Shot? That's facet. Shot? Shot? Should be foramen. Shot? All right, let's get an AP, AP view. So what I'm doing is again, this is the hardest part of the surgery, is gaining access to the disc. And you want to do it right, but you need the fluoro machine, the x-ray machine to do that. Yeah, I see. I may need to start more medially. Because the spine is rotated so far away, I need to start more medially. So I'm gonna have to probably do a separate incision for this. You feel anything there? Shot. So sometimes we just have to do two separate. Shot. You're doing really well, by the way. I'm going after your second disc, and it's extremely collapsed on my side. Oh, you're not making it easy for me. But I didn't expect you to, so don't worry. That's the facet right there. Shot. All right, let's go lateral. So you can see how the spine is curving, folks. We call that scoliosis. And where I want to be is a little bit above where we are with the tip of that second needle that's up above. I need to be a little bit higher. Actually, on the lateral view, it looks pretty good. Interesting. So as I go further in, it may end up being a better looking picture, so to speak. Pedicles are lined up nicely. The end plates seem to be lined up well. I think our fluoro is perfect, as good as we're going to get it. We could make it a little bit better. You can see the back of the vertebral body of L2, kind of a double shadow there under the pedicle. So we could rotate it slightly, like, you know what I'm talking about? This way. Let's try just a slight maneuver and see if that improves it. But I can't even emphasize how important it is. That's better. Let's try a little more, see what we can do. The most important thing here, folks, that's good. I think that's as good as we're going to get it. The most important thing is to have the fluoro set up properly for your patient. And it's not the same for every patient. It's completely different every single time. And if you don't do that step properly, shot, I'm hitting the facet. Want to go around it. I know it's a little uncomfortable. I apologize. Shot. Shot. Anybody know who this is? No? Oh, 80 buffs? Huh?
Don't remember, sir.
Oh, wait, so you weren't even born.
Oh yeah, I'm 81. Come on.
Really? Come on. Shot. 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 That's the facet. Shot. Oh, I was there. Shot. Shot. Sorry, folks. This is taking a lot of my concentration. Shot. Shot. Well, it looks nice on lateral, but let's see if it's really nice. AP. So you can be fooled if you just use one view. You can't use just one plane of x-ray. You need to see it in AP and lateral and sometimes oblique. But surgeons do things a little different. For me, yeah, we're too far lateral. We're back at that lateral spot. That's a giant bone spur, by the way, for those of you who can appreciate it. It's literally a fake disc that has basically developed. You okay? Shot. Try to relax a little bit. Is he off the fentanyl?
Is he what?
Does he have any fentanyl on board?
He's got 150 mics on board.
But is it worn off?
Oh, I just gave you some probably 5 minutes ago.
5 minutes ago? Let's go back to a lateral view. Let's see where we are. So that bone spur is very important because it's really trying to keep me from getting to where I need to be. And I need to see if I can find a way around it. I'm sorry that's so uncomfortable. But we're making progress. That's the good news. You're doing really well. Shot? Alright, to me that looks like we're at the back of the disc. Still there's some, looks like he moved a little bit, AP. This is definitely better than where we were before. Where do you feel that? Where do you feel the pain? Right where I was working? How do you know where I'm working? You can't see. I'm just kidding. You were right though. It is right where I'm working. But it's not going down your leg. That was, huh? What, are you need me or somebody else? So, you know, I never thought that I would consider myself to be a needle jockey as a neurosurgeon. Needle jockey is a term usually reserved for interventional pain management docs, because they really are needle jockeys. Because you literally have to jockey the needle. There's really no better description. To get from here outside to where you want to be on the inside, you have to navigate around structures, and literally it could be 0.5 millimeter that you have to turn your needle. And so we use a special needle that has a beveled tip. And a beveled tip means it's shaped, it's like not a flat tip, it's pointy. But it's pointy in a certain direction, and we know that direction. And we use that bevel to guide the tip of the needle. And that's very important. We wouldn't be able to do what we do without a beveled tip. So Dr. Patel taught me about that a long time ago, and really helped me in the very beginning, along with Dr. Young, to gain access. Are you comfortable? Is that a yes? All right. Is that your typical pain? How bad is it on a scale of 1 to 10? 10? All right. So the patient, for those of you, I'm sorry about that. I had to test your disc. You may have seen me do this before, and I can't tell you when I'm going to do it, because then you would be like very anxious, and the anxiety would obviously impact your pain score. A lot of people don't know that anxiety enhances the sensation of pain. Anxiety is basically activating your cortex, overactivating your cerebral cortex, which is where pain is perceived. Are you comfortable? So we don't want our patients being anxious. We want them to not be sedated during this part either. We want, during the discogram, we want to know if the disc is painful. And clearly this disc is painful. So that was L23. It was a 10 out of 10 concordant. Concordant means that's the pain the patient typically feels every day. How bad was that? A 9? All right. Another 9 out of 10 for L34. Nope, I want more, because you can see how scarred the back of that disc is. The dye isn't even leaking out. That's incredible. More dye. Yeah, I'm going to pull the needle back a little bit. We're going to put you to sleep in about 5 seconds. Actually, we can put you to sleep now. All right? And when you wake up, we'll be all done, and that pain you feel in your back should be gone for the rest of your life, as long as you don't re-injure your disc doing something you shouldn't do. All right, which you're not going to, right? You're going to follow the instructions. Well, I want you to bungee jump in a year, but give your disc a year to heal. Okay? All right, count out loud from 1 to 100, starting at 1. Nice and loud so we can all hear. You might feel a little burning in your arm as the medicine goes in. That's normal. Nice and loud. All right. So he's asleep. Our anesthesiologist did a great job. Thank you. Shot. All right. So you can see this disc is taking a lot of dye. Shot to fill up. My God. Shot. There we go. Now we've stained the track backwards towards the annular tear. So what makes the Deuk laser disc repair special is many things, but one of them is it's an endoscopic surgery, true endoscopic surgery of the spine. Not microendoscopic, endoscopic. Endoscopic is the least invasive surgery of all. It's less invasive than microendoscopic. Microdiscectomies are done commonly by most spine surgeons. They involve big incisions, and there's a lot of scar tissue, a lot of damage to the muscles and to the bones in the spine. We're not damaging any muscle. We're not damaging any bones. The only damage we're doing is a cut in the skin. And even a microdiscectomy and laminectomy, all the other surgeries require a cut in the skin, okay? So this is the smallest skin cut you'll find on any spine surgery. So we have the smallest incision in the world, and we don't cause any damage to anything below here. We literally pop into the annular tear where the herniation is, and we repair it. So what makes this Deuk laser disc repair very unique is that I do my endoscopic surgery different than other endoscopic surgeons. There's only about 50 endoscopic surgeons in the world that do true endoscopic surgery. Why? Because the equipment is so expensive to buy, and because the skill level to do what I do is not taught. None of this is taught, and it's too difficult for surgeons to learn. It literally takes an extra year or two of their training, and they don't put the time in. It's called a fellowship. They don't want to spend more time on a fellowship. They've already spent their whole lives in school, and they want to get out and make money when they're done with their residencies, so they don't want to do a fellowship, and that's just the harsh reality, okay? So I went and did a fellowship to learn the technique overseas, and I did fellowships, multiple fellowships with Dr. Young here in the United States, Dr. Tony Young. And I took time away from my family, my business. I said, you know what? Making money is not as important as an education. I want to go get a good education. I want to be the best spine surgeon in the world. So I invested in myself even after I got done with my residency and my fellowship at University of Florida in Gainesville. My fellowship was in epilepsy surgery. I was destined to be an epilepsy surgeon, and I ended up falling in love with what? Thank you for your concern. Thank you for your concern, but I know what I'm doing. Yeah. So I decided I wanted to do spine because even though I was on track to be an epilepsy surgeon, I realized that patients with spine problems, they were fixable. I mean, really fixable. Epilepsy patients can be fixed too, don't get me wrong. But I don't know, there was just a natural connection with people suffering with pain, and I was really good at doing the surgeries. And my results were better than pretty much my faculty that were teaching me. So I realized that I had a knack for curing people's back and neck pain that other surgeons didn't have. And so I was naturally drawn to do that, to take care of patients with spine problems. Because I knew there was a lot of people that had spine problems and that they were not getting better. And I realized, well, why were they not getting better was because the surgeons didn't do the surgeries properly. And I was doing the surgeries properly, and I was getting really good results. So naturally I said, okay, well, it's kind of like if you're Messi. I don't know, for those of you who don't know who Messi is, or Ronaldo, or Neymar. I mean, if you have to decide between a career in soccer or, working at the factory shoveling coal, and you have the skill and ability of Messi or Neymar in soccer, you don't go shovel coal. You do what you're good at. And I was really good at spine surgery. And what I mean by good was not like technically good. I was technically good, but I was able to cure back and neck pain. And I realized other people weren't, other surgeons weren't, and I realized that's where I have to go. I don't know, it's a calling, I think. I think that it was guided, like all of us that have things that we do better than others, unique skills. It's a calling. So I chose spine surgery because I was called to do it. I went into neurosurgery to be a brain surgeon. I did my neurosurgery training. I completed it. I did my fellowship in brain surgery. So I fully expected to be a brain surgeon at one point for many years. And so having a career in spine surgery was not my plan originally. I was going to be a pediatric brain surgeon like Ben Carson, and I was going to take brain tumors out of little babies, save their lives. Of course, I tried that during residency, and what I learned is that that's not for me. I don't have the patience, unfortunately, to deal with some of the people involved in that field. And to be quite honest with you, like I said, the skill with other things developed, and I just moved to a different path. Shot? Do we not get a shot, or is that our last shot? All right, good. So here I am, and even in spine surgery, I wasn't settled. Once I graduated from my program, I wasn't settled because I was doing a bunch of fusions back then, and decompressions and fusions. That was very popular. It had great results. And then I heard about this endoscopic surgery. At first I laughed it off, but my better half told me, go learn, go see what it's about. So I did. And once I witnessed the results, the results is in the patients and how they did, how much better they did than open surgery, I was astounded. And I wanted to learn more. I wanted to see where this technology could really go if you did it the best that could be done. Because a lot of the doctors that I'm as mentored by, I think that the procedures could have been done better. I watched their technique, and I realized that their surgical technique lacked in many ways. It could have been improved upon, but for some reason they couldn't see that, but I could see it. So I took their technique and I made improvements, and certainly the improvements ended up resulting in better outcomes for patients, like better pain relief and faster recovery, etc. And so I just went with it, and pretty soon I realized I was doing the endoscopic surgeries pretty different than the people that taught me, but I was getting much better results. So he's moving around a little bit. It doesn't bother me as long as he doesn't come off the table, but you may want to, if you can, get him a little deeper. So we're inside the disc, and the metal you're seeing, that metal wall there is the tube, the endoscopic tube. And the blue fiber is the laser, and the red you're seeing is the targeting beam. It's visible light. The laser, of course, itself is not visible light. The laser beam is invisible to your eyes. this is a holmium YAG laser, standby laser. Holmium YAG lasers are medical lasers. YAG stands for yttrium, argon, and garnet. And the yttrium, argon, garnet is the elements, chemical elements that are used to produce the laser beam. Every laser beam has a different characteristic depending on, you know, how it's produced. There are CO2 lasers that use carbon dioxide, and there are YAG lasers like I'm using. There's other types of lasers as well, and I use this laser because this was the laser I was taught to use by Dr. Young and also the Koreans overseas where I did my training. And I have had great results with this laser ever since I started. So I've had no reason to change what I'm doing. And this laser has some advantages over other types of lasers. So certain lasers have qualities that make them better or worse for certain applications. And CO2, for example, was not a good option because of the temperatures associated with it. This laser is cool, a cool laser. It's cold. Of course, you pay more money for it. It's a much more expensive laser. But it's better for the application of fixing discs. So, and that's what we're here for after all, right? This is part of our annular tear right here. That's a herniated fragment right there. And it's stuck on the annulus from inflammation and scar tissue. And I'm releasing it. At the same time, I'm debriding the annular tear. And remember, this patient has pretty degenerated discs. So people ask me, what is this technology good for? Is it good for herniated disc? Yes. It is the best treatment in the world for herniated discs that cause symptoms. Is it good for degenerated disc? Yes. This is a degenerated disc. It's beautiful for degenerated disc. Can it be used for patients who have pain from scoliosis? Absolutely. Because the pain from scoliosis comes from the disc, not the actual scoliosis itself, unless they have severe scoliosis. And if you have severe scoliosis, like 30-degree angle, then you got other issues. You got pain from instability and from imbalance. And that's different. Any questions?
Yes, we do have a question.
All right, let's hear it.
One of our viewers is wondering, do the lasers used in orthopedic surgery differ from the laser used for DLDR?
So is the laser used for orthopedic surgery different than the laser used for DLDR? The answer is it can be the same. It depends on the hospital where they're doing their surgery. Hospitals have budgets and they buy equipment based on their budgets. And so a smaller hospital may not be able to afford this type of a laser. They may go with a cheaper laser. So they may have like a CO2 laser and other things, other considerations, like if there's a general surgeon or a urologist that's doing laser surgeries on other parts of the body, and they may have already like say a CO2 laser there for those surgeries, well, they may want to just use that CO2 laser because they already have one, and they may not want to buy a second type of laser for just for these surgeries. So your question, to answer your question, it's the orthopedics can use this laser for sure, but do they? I don't know. These are very expensive lasers to buy. Honestly, probably the most expensive outside of industrial lasers. They're probably the most expensive medical grade laser that you can buy. So a lot of hospitals don't have the budget, they don't have the interest, they don't get the payment from the insurance company to cover the expenditure. So it's hard to say what other surgeons use. It depends on what's available. The reason I'm using this laser is because I'm the guy who makes the decisions here at Deuk Spine Institute about which laser to buy. So if an orthopedic came here and did surgery here, they would have to use this Homium YAG laser. But I'm sure they would be delighted to use it. It's a great laser. It's really the best you can buy. And, you know, there were really two companies that made this type of laser when I started out doing these surgeries 13 years ago. One was Luminous, which is the laser we're using currently, which is the best. And the other company was, oh yeah, I gotta remember. It's been a while. But they're not doing so well because their laser's not as good. That's my opinion, of course. Trimedyne. Yeah, Trimedyne is the name of the other company that manufactures Homium YAG lasers. But like I said, they have a very small market share because, number one, the laser's not as good. Number two, their customer service is not very good either. It's terrible. And, you know, people like me want good customer service. And Luminous provides great customer service. That's who we got our laser from. We just bought the laser. This is a $100,000 laser. I've been using a rental all these years to save money, and because it's a big expenditure. And we're not at a hospital. We're at a surgery center. This is a Deuk Spine Institute, basically, Surgery Center of Vieira, our sister company. And so these are paid for out of our pockets, the doctor's pockets. So we always want to be cost conscious about what we buy, but at the same time, I'm not willing to buy something cheap that's going to perform less than the best. So I'm always going to buy the best, but if there's a opportunity to save money when buying the best, I'll take it. Say, for example, if this laser was available used, like 2 years old or 3 years old used, I would have bought it. But there's none of these lasers available used that are 2 or 3 years old. You know, once you get past 2 or 3 years old, the software is not up to date, and some of the hardware has taken a beating, you know, where it was, and you can't trust the laser to work properly. So I wasn't going to compromise quality to save some money. There was one that was available that was like 10 years old. It was a lot less money, but I said no, because I want a laser that actually does its job properly. The results of my surgery require a laser that works properly. And anytime you start cutting corners in medicine and going cheap, you're going to compromise results, period. And unfortunately, that's what all these hospitals are doing. Doctors' offices are doing. They're going cheap, cheap, cheap because they're getting paid less and less by the insurance companies. Every year we get less money for what we do. And so how can you afford to stay in business unless you cut corners? Well, that's why a lot of times we don't take insurance, because insurance wants to pay us too little, and there's no way we can do the surgery with the amount of money they're paying. It's just we'd be losing money on every single patient. So we have to say no to the patients. We can't accept your insurance for this procedure because your insurance is going to pay us so little that we would literally be paying for your surgery, and but a lot, and we just can't accept that. So people need to wake up and realize their insurance is really their enemy as long as it's not paying properly for their medical care. They can authorize your surgery, but if they don't pay properly, the facility or doctor aren't going to get paid enough money to stay in business. That's why you're seeing all these doctors' offices closing, is because they're not getting paid enough money. They can't afford to stay in business anymore. I see doctors' offices closing down all the time because they go out of business. You never used to see that 15 years ago because they were making enough money to stay in business, no problem. But now you have to be a really good business person just to stay in business in medicine. A lot of hospitals are closing down. Every year we're losing about 30 hospitals in the United States, closing down, going out of business. And forget about the hospitals that are closing down. Let me ask you, which is worse, a hospital completely closing down or a hospital that can't afford to do your treatment that stays open? We're seeing a lot of that too, where hospitals are just denying doing certain treatments for patients because they're high-cost treatments that are not paid well by the insurance company. This is a tragedy in medicine. Seriously, it should never be happening. Americans should not be denied good health care because their insurance is not going to pay for it. The insurance companies literally are collecting hundreds of billions of dollars a year from your money, from your boss paying them. You know, your employer is paying those health plans, premiums, and that money is being kept by the health insurance companies. They're called third-party administrators. They basically get a bonus for every dollar they save that they don't pay. So all they're motivated to do is to deny paying it. And that incentivization of giving them a bonus by denying payments to your doctors and hospitals is the whole reason why the denial rates are so high. And this is kept from the public eye, by the way, but it is part of the contract between your third-party administrator like Cigna, United Healthcare, Aetna, Blue Cross. They have a contract with your work. And in that contract, it literally says any money that's not used gets split, basically. So, of course, if they deny paying, they're going to have more money at the end of the year to split between the employer and themselves. So they're basically paying themselves not to pay for your medical care. People don't know this shit, and I try telling them, but they don't listen. You got to go to the politicians. You got to write laws that prevent insurance companies from this nonsense, because they're completely incentivized not to pay for your medical care. And you wonder why they're denying so much stuff, because they get money by denying. Anyway, I always seem to be coming back to the same topic lately with these surgeries. What other questions do we have?
None so far.
Good. Let's crank some music up then. Is this still my my phone? Love is a battlefield. It's funny to think that this is old music, right? All right, I think we're good. You have the epidural space there. You have one vertebral body end plate there. At about 9 o'clock, you can see it. You have the other end plate there. And the herniation is pretty much gone. I may want to grab some of that out. Laser off. So this surgery done endoscopically uses two instruments. I use a laser and I use pituitary rongeurs. That's this metal thing going in. And the pituitary is really good at grabbing like chunks of herniation that need to come out. And the laser is really good for everything else. The actual annular debridement, which is the really time-consuming part of the surgery, takes up probably 95% of the surgery. The annular debridement is done with the laser. And I just don't want any of these pieces of disc material to be loose and come out after surgery. So I'm just checking them to make sure they're tethered down inside and that none of them are loose pieces, because we don't want anything loose coming out of that hole. Looks good. Think we've gotten everything we need to. Let me see the laser one more time. I might be able to get just a little bit more of that inflammatory tissue there. So for those of you who watch our program regularly from Deuk Spine Institute, you know that we broadcast live all of our spine surgeries at Deuk Spine Institute. We've been doing that for the last 5 years. And we broadcast live for educational purposes. We want to educate the world on the most advanced spine surgery available in the world. You're not going to find this surgery everywhere. The types of surgeries that we do here are done outpatient, all of them, and they're really able to be done outpatient because of the technique that's used. And that technique is unique to Deuk Spine Institute. Sure, we may do a fusion, but we do a fusion with a Deuk spine technique. Or we do the Deuk laser disc repair right now with a technique that's different than other endoscopic surgeons. So it gives us an advantage for our patients. They get a better result, and they have a much faster recovery. All right, I think we're done here at this disc. Standby laser. And the tip of that, I think, I don't know if that tip needs to be, right? So we need to rescore it. But let me just use it one more time here. All right. You have another question, Sean?
We do. A viewer has shared her story. She says, I have degenerated discs in my cervical spine with encroachment on my nerve root. My hands and arms have been going numb for months, and the muscles between my shoulder blades spasm constantly. The doctors where I live in Alabama have said that the axial damage to my neck is so bad that I am not a candidate for their surgery, and one even told me with the extensive damage I shouldn't even be alive.
Well, so we have somebody who has 2 herniated discs in their neck, and they're getting numbness in their arms, and they're being told that there's no surgery that can be done to fix them. That is completely untrue. We could fix you in an hour and a half. Doesn't matter how extensive your disc damage is. Whether I do this laser surgery or I do an open surgery, I can fix your discs. So come see me, get a second opinion. Anyone who tells you if you have pain in your neck or back that you're not fixable, that is not true, folks. There's probably 1 in 500 patients that I can't fix. The other 499 we can. It just takes advanced surgical techniques that your doctors are not capable of doing. It's that simple. There's a limitation to what people can do. You understand? I cannot fly the international shuttle, space shuttle. I'm not an astronaut. I don't have the ability to do that. Most spine surgeons don't have the ability to fix those kind of problems. And unfortunately, you have to go to someone who can. And that usually means traveling. All spine surgeons are not created equally. There's huge differences. So if you choose to live your life in pain, that's your choice, but you don't have to live your life in pain. You can come to Deuk Spine Institute and we can fix just about 98% of spine problems that cause pain. Now, we don't do tumors usually, and we don't do infections, which do cause pain. But we take care of fractures, we take care of herniated discs, we take care of facet pain. You know, we take care of pretty much every other cause of back pain. So whatever is causing your back pain, whether it's muscles, joints, the disc herniations, we can fix it. But most other surgeons cannot. So we have people that come here all the time, every single week, who have been told there's no hope, and we fix their pain. So don't believe what you're hearing from these other doctors when it comes to back and neck pain, if they tell you it's not curable. It is. It is curable. But you have to go to the right place. I'll give you an example. There are certain types of cancer that are now curable. Not all cancer, but certain types of cancer are curable. Well, not so long ago, we were telling patients they're not curable. And then some doctor discovered how to cure them. It wasn't me, but some doctor figured out how to cure that cancer. And now they're being cured. And now that knowledge of how to cure that type of cancer is disseminated around the world. And other doctors are using it. Well, that's why we broadcast. We know how to cure back pain and neck pain. We're trying to disseminate that knowledge for the world to hear and see. Because honest to God, people living in chronic back pain and neck pain, sometimes living with that pain is worse than living with cancer. It's true, and I don't say that because I personally experienced it. I say that because I have a lot of patients who've lived with chronic back and neck pain that say it's worse than cancer, because they have cancer. And they want their back pain fixed. They want their neck pain fixed, and we can fix it now. So just like there was a doctor who discovered how to cure that cancer, and that was the first doctor to do that, And if you went to that doctor, they could cure you. And eventually other people learned how to do it. But I'm one of those doctors who are a pioneer in the field of spine surgery with back and neck pain. And we're curing back and neck pain, but we're doing it ahead of everyone else. So if you want it cured, you got to go to the right place. That's all I can say about that. But I think most of you understand that. Shot? All right, we got our guide wire in. We're taking our needle out. Shot? So I'm kind of right at the front of the disc. I don't want to go in any further with my guide wire. I got to make an incision because I didn't do an incision here. I had a different starting point for this needle. Remember, I tried it going laterally and I couldn't do it. I couldn't get the right trajectory. So I am now moved more medially, which is typically what I need to do when I go up the spine to higher levels. And by going more medially, I can get into the disc properly. Shot? So the tip of that dilator is right at the foramen, the backside of the foramen. And I'm entering the foramen. And now we're inside the foramen, and I'm at the back of the disc. And I'm going to enter the disc next. He's moving around because he's uncomfortable. Yeah. So the reason the patient's moving is because what hurts this patient is their disc. And I'm touching the back of the disc with the tip of this hard thing. So I'm stimulating the area where they're hurting. And our anesthesiologist has done a great job because he's keeping our patient light because we don't want our patient to be over-sedated. So only when we need the patient sedated do we give them sedation. The rest of the time we keep them light. And right now he needs a little sedation because we're in the most painful part of the surgery, which is going through the annular tear. Remember I told you the annular tear is where the pain comes from. Shot? It's always important to be aware of where your tools are inside the patient. You want to have full control. Shot? I'm watching the guide wire, I'm watching the dilator. The dilator is going in nicely. Our anesthesiologist, again, has done an amazing job. Because if the patient's feeling pain, he's going to tighten up his back muscles. Nope. When they tighten up their back muscles, that clamps down on the disc, and it makes it harder for me to get inside. So by giving the right amount of sedation at the right time, we keep the patient safe, and we make the surgery safer. Shot? It's all about safety. Shot? We have an incredible safety profile with this surgery. I've done 1,000 plus of these surgeries in the last 13 years. Not a single complication. Not a single complication. There's no other spine surgery in the world ever that has ever been done and probably ever be done that has 0 complications in 1,000 surgeries. Sure, you can do one surgery and get away with it without having a complication, but to do 1,000, it's impossible. There's no such thing in today's day and age. And if I tell other surgeons that, they would never believe me. But that's okay. I really don't care whether they believe me or not, to be honest with you. I stopped caring about what other surgeons think a long time ago when I realized how incompetent, selfish, greedy, ignorant, and pathetic most of them are. Shot. And there's other adjectives I could use, but I would have to keep going for a long time. What's going on with the radio? I'm getting texted? All right. That's a long text. All right, do we have any other questions? Yes, no, maybe so?
Not at the moment.
Huh?
Not at the moment.
Not at the moment. People are mesmerized. Well, folks, this is your opportunity to ask a board-certified neurosurgeon his opinion on life, on things. Don't blow it. I won't be here forever. I can't hear the music. Oh yeah. Sounds like Guns N' Roses maybe? Oh yes. One of my favorites, November Rain. So we're inside the second disc. It's more collapsed. You can see all that grungy granulation tissue. That's what we want to get rid of. Oh, this texting is killing me. You're kidding me. Oh no. Who is texting? Is it a 702? Yeah. Two from who? Alec Walsh. All right. A group email? Thank you. Don't these people know I'm listening to Guns N' Roses? Oh man, that is so disappointing. No, I don't think we can. Just hit rewind. Oh, perfect. Thank you. This is, you know, why am I having trouble twisting this? Yeah, he's starting to move a little bit. Luis, watch the patient.
We better now?
It is better, but it's still hard to twist. Huh? Is he okay? Doctor?
Yeah.
Yeah, we got about literally 5 minutes left and we're done. Oh, yeah. Yeah, call Patel. So this patient is one that we believe has not just pain coming from the herniated discs, but also the facet joints. So traditionally, this patient would end up having a fusion, and that would take care of the facet pain and the disc pain both. But this patient didn't want another fusion. He was smart. He said, I've been through that before, and I do not want to go through that fusion again. So he chose to have the Deuk laser disc repair done with a rhizotomy. And the rhizotomy is something that I let Dr. Patel do because he's the best in the world at it. Literally the best in the world at it. So he'll be in here shortly to do the rhizotomy. How many people want to watch the rhizotomy? If I get 5 viewers that say, we want to watch the rhizotomy, then I will keep this live stream going on the rhizotomy so you can watch. Then Dr. Patel can be famous too.
We have a question.
All right.
A
We
viewer
have a
asked,
question.
how is this process different from surgical cement used to fill voids?
How is this process different than surgical cement? Surgical cement, did I hear it correctly?
Yes.
Used to do what now? To
Fill voids.
fill voids. All right. So surgical cement is used in fractures of the vertebral bodies, vertebral body fractures. So this is not a fracture case. This patient doesn't have a fracture. They have a herniated disc. You never use cement on a herniated disc, ever, 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 ever. Nobody in the world does. We use cement on fractures. So it's different because we're treating the washer between the bones. The surgical cement treats the bones. They're called vertebrae. And that's called vertebral augmentation. The most common vertebral augmentation technique is the kyphoplasty, is where you use a balloon and you open up a cavity in the middle of the bone and then you use cement in there. I apologize for the poor visibility, but it's really not my fault. This is just the patient's epidural veins oozing a little bit of blood, and that's making the visibility poor. Fortunately, I've been here before, and this is not my first rodeo, so I know what to do. Not that I can do the surgery blindly, but I know what needs to be done, and I can, once in a while, I stop, I spot, and, can you pull it towards you? Yeah, there we go. That's better.
We have another question.
Sure.
One viewer says they had an instrumented fusion done in their back, and the scar tissue has made their pain worse. What should they do now?
All right, so somebody's had a fusion and their scar tissue is making the pain worse. All right, so number one, you can be fixed for sure. Okay, and what's causing your pain is not necessarily the scar tissue. What's causing your pain is abnormal movement and pressure. It's probably the disc that's causing your pain. You probably have a herniated disc either above or below your fusion. And if you do, that's where your pain is likely coming from. The other source of pain after a fusion that's common is the facet joint. And that's exactly like this patient, by the way. For whoever asked that question, this patient is basically you. This patient had a fusion. You can see the fusion on the x-ray. And now they have pain at the disc above the fusion. And that's why we're treating the disc above the fusion. And then they also have facet pain, so we're doing a rhizotomy for the facet pain. In other words, this could be you, and I would expect you to wake up and your pain to be gone. So I don't think it's scar tissue, but if it is, I can get in there with the laser and I can remove whatever needed to be removed. It's really a remarkable surgery. This is the surgery you want right here. Or we could do another fusion at the level above or below wherever your pain's coming from. Either way, we can fix your problem. But you're welcome to submit your MRI for a free review. I'm Dr. Ara Deuk-Majan, CEO and founder, and I do a free MRI review for people that want it. And in that free MRI review, I literally review your MRI, and if we need to review a CAT scan, we can do that too. And I will tell you what I think you need done to fix your pain. Okay? And it's no obligation. You don't have to do anything. You don't have to pay for it. You don't have to treat with us. You just submit it for an opinion. And you get my free opinion for whatever that's worth to you. It could be life-saving. All right, for those of you watching, if you didn't know, Deuk Spine Institute has an app available on iPhone and Android platforms. It's free. It's called the Deuk Spine Institute app. Surprise, surprise. And in that app, there's lots of valuable information. It's probably the best spine app available in the world today, 2019, and it's free. It allows you to communicate with our staff. It allows you to set appointments to talk to doctors, video conferencing, MRI submissions. It has a library database of very useful information on common conditions that cause pain. It has access to testimonials of patients who have back pain for a long time or neck pain for a long time, and then they're cured. They're cured at Deuk Spine Institute. We cure people every day here of chronic pain. And we do it better than anyone else in the world, safer. We're the fastest recovery available in the world. This patient will be recovered from their surgery in about 24 hours. Completely. Pretty much every single one of our patients, their pain is gone right after surgery, and they stop taking any medication for the surgery, like pain pill, Tylenol, whatever. They stop after 1 day. So their surgical pain is gone in 24 hours, and their preoperative pain is gone right after surgery. It's pretty remarkable. You won't find this anywhere else in the world. All right. Did we get 5 people wanting to watch the rhizotomy?
No one mentioned it in the chat.
Huh?
No one mentioned it in the chat.
No one mentioned it in the chat. Well, too bad. No rhizotomy for you.
We do have a question for you, though.
Lower the music, please. I'll take the question. Come here and put pressure.
One of our viewers is wondering,
You want to pull
with
that
your
that
son's
way?
career taking off, do you see yourself taking time off from surgeries in the near future?
Oh, somebody asked a really good question. Good morning, Sue. How are you? Do I see myself taking time off from surgery in the future with my son's career taking off? The answer is yes, I most certainly do. So for that question, it requires an interesting answer. I was just on the phone with my son. Arias is 15 years old as of like 2 weeks ago, and he has been signed by a sports agency, the 5th largest in the world. They just opened a motorsports division, and the director of motorsports wanted to sign him as their first driver ever because of historical significance, obviously, and because he's believed to be the top driver in the United States to go to Formula One. Anyway, we've been waiting for a sponsor, and we apparently have a sponsor now. They won't tell me who it is, but it's a very good match for him for the rest of his career. The sponsor is actually going to be laying down millions of dollars for his career to go to Formula One. So we're pretty excited. We're supposed to go meet the sponsor in January in Chicago at the agency. And Arias will probably be, it looks like he's going to be in Europe, in Genk, in Belgium the whole summer for 3 months. Basically part of a special program for top drivers in the world. He'll have world champions there. He'll be competing against, he is not a world champion, he's a national champion. He's champion of the United States in go-karting. But he's not a world champion, but hopefully that will change soon. I'm going to call our EBL 15 mils. No complications. And Arias will be in Belgium this summer, really the whole summer, as part of this program with the top 20 drivers in the world competing against each other on track every day, developing a dossier that will be previewed by basically all the Formula One teams, NASCAR teams, IndyCar teams, as a feeder program. I can't give too much information out about it because I'm under a non-disclosure. But let's just say that I'll definitely be in Europe a few times this summer, visiting him, making sure he's not spending too much time on a cell phone, playing video games. So will that change in the future? Yes, obviously if he's racing. The expectation is by the end of this summer, he's going to be signed with a Formula One team, and we'll start F3 and then F2 in Europe and then Formula One. So if that happens, which is what's expected, I'll be definitely taking some time off at work, but probably no more than a week or two at a time. I'm certainly not going to retire. I really love what I do, and there's somebody I can certainly train to carry the load that wants to learn this procedure. That's Dr. Patel, and I think he's perfectly capable of doing it. But I have to complete his training. So don't worry. The Deuk laser disc repair will not die out, or not fizzle out. And there's literally hundreds and hundreds of videos online. So worst case scenario, a very good surgeon could learn at some point in the future from my videos. And we have an archive of all the surgeries here. So don't worry. There will always be available the Deuk laser disc repair. We're doing rhizotomy.
Bilateral, same levels.
Is that Dr. Patel?
Oh, no, that was.
Is he coming? All right, good. Great job, everyone. Thank you so much. So for those of you listening, I'm really disappointed nobody wanted to watch the rhizotomy. But that being said, it's okay. I forgive you today. Thanks. Yeah, perfect. Thank you so much. Great job, by the way. Anyway, I'm going to head to the conference room in a few minutes, and I'll be there so I can answer more questions. In the meantime, this is Dr. Deuk. We just finished the Deuk laser disc repair, right side L23, L34, adjacent to a prior fusion on a patient who developed adjacent segment disease with degenerated herniated discs. And he'll be coming out of the operating room in just a few minutes once Dr. Patel completes the rhizotomy procedure. In the meantime, I'm going to go see the next patient, who's another lumbar Deuk laser disc repair. I believe 1 or 2 or 3 levels, I don't remember. But I'll figure that out during the timeout. And then we have a cervical Deuk laser disc repair to follow that. So that's 2 herniated discs in the neck. Talk to you soon. Save your questions and start typing them up.
All right, we have one viewer question. A viewer wants to know, can chronic pain from a pinched nerve at L4, L5 due to disc degeneration and arthritis be cured permanently with surgery?
All right, one more time.
Can chronic pain from a pinched nerve at L4, L5 due to disc degeneration and arthritis be cured permanently with surgery?
I just filled, yeah. Hi. Okay, great. So Dr. Deuk here. I'm with Sean, and great question. Can chronic pain from a pinched nerve at L4-5 due to disc degeneration and arthritis be cured permanently? Absolutely. Yes, it can. It can, easily. We do it every single day here at Duke Spine Institute. It's not a tough problem to solve. Yeah, that's an easy one. So chronic pain from a pinched nerve at L4-5 due to disc degeneration. When you have a pinched nerve, and I usually talk about this almost every surgery. I haven't talked about it today, but pinched nerves cause leg pain, not back pain. And if your pain is shooting down your leg and only your leg, then you have a pinched nerve. If your back hurts, then the back pain is not coming from a pinched nerve. It's coming from the disc herniation or degenerated disc, or it's coming from the facet joint, or both. It's not coming from anything else. Now, if it's lower back by your buttocks, it could be your sacroiliac joint, your piriformis muscle, your coccygeal ligament. It could be a fracture. But back pain has specific causes, and it's very easy once we have the right diagnostic tests to figure out what's causing each person's back pain. So, for example, in this patient, we figured out his back pain was coming from the disc herniations above his fusion. We tested those discs during surgery, and lo and behold, guess what? The discs were painful. So once I knew his discs were painful, I knew that the Deuk laser disc repair was going to work, for sure. And so most of the time I can tell if somebody has a painful disc based on a physical exam by me looking at that patient where their pain is and asking a couple of questions, and within a minute I can usually figure out where their pain's coming from, literally within a minute, 60 seconds. So figuring out where the pain's coming from is the most important thing your surgeon will ever do, your doctor will ever do in terms of curing your pain. Because if the doctor cannot identify the specific cause of your pain, there's no way they're going to be able to cure it unless they get lucky. Because there are literally 21 things in the lower back that cause pain. And the treatment of cause number 13 will not fix any other causes. So as a doctor treating chronic back pain, you have to be very sure of the cause. And the cause can be figured out 100% of the time. 100% of the time if you have a qualified physician. So here's the problem. You're listening to this broadcast, where you're living, there probably is not a qualified physician. I'd be willing to bet $100 you don't have a qualified physician to fix your back where you're living. And the reason I can say that with confidence is I literally have people from all over the world come here, and they all tell me the same thing. They have a herniated disc that's easy to fix, and they say, I've been told that it can't be fixed, that the pain can't be fixed. So I know by my patients, I know by talking to people from around the world living in chronic back and neck pain, that they don't have anyone near them that can fix them. They may have a spine surgeon, just like me. They may have a neurosurgeon who does spine surgery, but that doctor can't fix them. That's the problem. That's one of the reasons we do this broadcast. The main reason we do the broadcast, if there were spine surgeons all over the world that could fix people's back and neck pain, then people wouldn't be living with back and neck pain. Number one. And number two, we wouldn't be doing this broadcast because there's no need for it, because people have access to doctors that can cure their back and neck pain. The problem is, and the reason we do this broadcast, is that there aren't doctors that can fix back and neck pain. Even though they're the same specialty as myself and Dr. Patel or Dr. Damola, our doctors here at Duke Spine, they can't fix the pain. You understand? And so that's really one of the main messages that we have to broadcast, is that your doctors where you live are not going to be able to fix your pain most of the time. So the reason for that is because they don't know where the pain's coming from specifically. You can't say the back. The back is not specific, okay? It has to be the left L3-4 facet joint, the right L5-S1 facet joint, the annular tear on the disc herniation at 5-1 on the right side, the left side L4-5 annular tear. I mean, literally, you have to be able to pinpoint exactly the source of the pain. So let's go through all the sources and count, okay? You're going to count for me. You ready? We have the left L1-2 facet, the right L1-2 facet, the left L2-3, right L2-3, left 3-4, right 3-4, left 4-5, right 4-5, left 5-1, right 5-1 facet joints. So those are your facet joints. Any one of them can cause horrible pain that needs to be treated and fixed. But if you don't know which one, because you don't have an interventionalist that can do a diagnostic medial branch block, then you're not going to figure it out. Then you have the L1-2 disc on the left tear, right tear. So that's two more. And then you have the L2-3 disc, left annular tear, right annular tear. Then you have the so we did 1, 2, 2, 3. Then you have 3, 4, left and right, 4, 5, left and right, 5, 1, left and right. So those are annular tears. What are we up to so far?
20.
We're already up to 20. That's 20 causes. And then you have the right and left sacroiliac joints. That's 22, right? Then you have the coccygeal ligament. That's 23. You have the piriformis muscle, right and left. That's 25. You have fracture of vertebrae, L1, 2, 3, 4, 5, or sacrum. That's what? 31. And then you have kidney problems, which can manifest as back pain, like a kidney infection or a kidney stone. Right, so let's just call the kidney as, where are we at, 32? 32 causes. Then you got muscle spasms, right? Some people have muscle spasms. That's whatever, 34. And then you have fibromyalgia. Then you have myofascial pain syndrome. So how many is that?
35.
That's 35, okay. And then you've got, believe it or not, hip problems that can manifest as back pain. And it's hard to tell for some people. So let's just call that 36, right? Hip problems. Problems with your hip joint or your trochanteric bursa, your posterior capsule. Really, then you got infections and tumors. So where are we at?
With infections and tumors, that'd be 38.
38 causes of back pain. 38. 38 potential causes of back pain. So when a patient walks into a doctor's office and says, I have back pain, there's literally 40 causes that could cause it. 38, 40 causes that can cause it. And so which one is causing your pain? That's really hard to figure out. It takes very special tools, diagnostic tools they're called, right? And those tools are not available almost anywhere. They're very rare to be able to find them. Literally every state may have one place that has the diagnostic tools needed to figure out where each patient has their pain coming from. So Deuk Spine Institute is a center where we have all the diagnostic tools needed to figure out where the pain's coming from. So step one is diagnose the source of the pain. Once you've done that as a doctor, you can then start treatment, right? That's what we do at Deuk Spine Institute. We first diagnose the cause by ordering MRIs, CAT scans, x-rays if needed, EMG, and then doing diagnostic blocks with Dr. Patel, whether it's a medial branch block, a facet joint injection, a sacroiliac joint, piriformis, coccygeal ligament, whether we diagnose a fracture on CAT scan and then evaluate it with the bone scan to see if it's hot, causing pain. If there's a tumor or infection, we work those up separately with blood work. Long story short is that if your doctor can't diagnose the source of your pain, which is 99.9% of spine doctors, whether you're talking chiro, spine surgeon, interventional pain management, primary care, whatever, occupational medicine, those doctors cannot diagnose the source of the pain. I guarantee you. I would literally stake my life on this. That's how confident I am. And I don't stake my life on anything. Then how are you going to get cured if the doctor can't figure out what's causing your pain? Right? So that's one of the reasons we do this broadcast, is we want people to understand you have to go to a specialty center if you want your back fixed. Don't just go to your community hospital, local hospital. Don't go to your big city hospital expecting them to cure your back pain. We have people go to the Mayo Clinic all the time. They're just an hour away from us. And they're like, oh, I went to the Mayo Clinic and they couldn't figure it out. They say it's non-curable. Bullshit. They can't cure it. It's non-curable to them. They're right, but not to us. You need to go to the right place. I'll give you another example. Right? So reputations are sometimes not deserved for certain fields of medicine. Take the Mayo Clinic, for example. They're probably very good at internal medicine, but they're not good at spine care, okay? My opinion, I'm not bashing the Mayo Clinic. I'm just telling you, I have a lot of people that go to the Mayo Clinic, can't be fixed. They come to me and I fix them. Why? Because I'm a lot better than the Mayo Clinic. It's just simple. Deuk Spine is better than the Mayo Clinic. So don't just look at reputation. Don't just look at the name and say, oh, Mayo Clinic, they got to be good. No, a lot of times they're not good. They may be horrible for that problem. All right, but they may be very good for treating cancer. They may be absolutely horrible for treating degenerative spine conditions. It all depends on who their leadership is, who is in charge over there, and what their knowledge base is, and how committed they are to their patients and getting their patients fixed. At Deuk Spine, you have the most committed doctors in the world in spine care, literally. Now, there may be other people as committed as we are. They just want to fix the patients. They love it. That's what their passion in life is. But they're not more committed than we are. They may be equally committed to us, but that's still rare. How many of you go to the doctor and feel like the doctor is not really committed to fixing your problem? Probably a lot of people. Raise your hands, right? Why is that? Because honestly, a lot of doctors are just overworked today. They're burnt out. Medicine is just putting demands on them. The insurance companies are putting ridiculous demands on us with all the paperwork and documentation. By the way, we don't get paid for filling out the paperwork, and that's what we spend most of our time doing. And now it's up to about 75% of our time is paperwork. But that's what the insurance companies want, because filling out paperwork is not billable. They don't pay for a doctor to fill out paperwork. They clearly state in their policies, we're not paying you to fill out your notes. So the doctor's notes have gone from being one paragraph when my dad was a doctor back in the 80s, and he got paid more than we're being paid now to fill out 30 pages of notes, because the insurance company won't pay you unless you fill out 30 pages of notes. So medicine is totally screwed up by, guess who's screwing it up, right? The insurance companies. But you're feeling the pain. You, the patient, are feeling the pain because doctors are so distracted from medical care by the insurance industry. And the government is not making it any better because the government's either stupid, the people in the government are dumb and they can't figure this out, or they're being bribed and paid off. But either way, it's bad for you, the consumer, the American public, or the international public. Your government has failed you. The decline in healthcare quality over the years is a result of your politicians writing laws that allow the insurance industry to not treat you, basically justifying legally the insurance industry to not treat you. And by the way, the insurance industry is still fighting this battle to make it even worse for you. And they're winning. That's the worst thing about it. They're winning. Right now there's legislation in federal legislation in the House and Senate, primarily the House, that is trying to restrict healthcare providers like hospitals and doctors from balance billing the patients. It's the worst decision we can make as a country. Because if doctors and hospitals can't balance bill the patient for unpaid bills, that means the insurance company doesn't have to pay the unpaid bills. You see, an insurance company only pays what the patient owes. And if the patient doesn't owe anything because the law prevents doctors from billing them or hospitals from billing them, then the insurance companies don't have to pay. This is really about the insurance companies. This law is not about protecting patients. It's about protecting the insurance companies from paying more money. And what's going to happen is going to put doctors and hospitals more out of business. You're going to see a massive number of them going out of business because we're barely holding on by a thread by being able to charge fairly for our services. And we don't get paid fairly by any means all the time. We get paid maybe 5% of the time fairly. So if you take that 5% of the time being paid fairly away, you're talking about a system that's already on the brink a massive financial failure. Hospitals literally are running on margins sometimes of 0.5% of their revenue. Many of them are. And the average hospital profit, you know, 5 years ago, the number was true, was about 2% of their gross revenue. So if you take away a hospital's profit from these patients that have insurance companies that won't pay the bill, so they have to balance bill the patient because the insurance won't pay, and then the patient doesn't have to pay, well, the insurance doesn't have to pay. The only recourse a hospital has to go after the money is to bill the patient, and the insurance company's on the hook for that. And the insurance companies don't want to be on the hook for that money that they're not paying. You see, they're not paying it because they don't want to be on the hook for it. So now you have to go after the patient, and then you make the insurance company liable because the patient's found liable in court. Well, if you take that away, then the insurance companies don't have any obligation to pay at all. And literally, this whole system is on the brink of catastrophic failure. And if this law passes the way it's written, by one proposed law version, we're all screwed. Now, fortunately, there are some sensible people. Apparently, a Democrat from Massachusetts and a Republican from Texas have now proposed a new version today of the patient balance billing law that says that if there's money unpaid by the insurance company owed by the patient, that they would go to arbitration with the insurance company. So the fact that they're acknowledging that an arbitration process between the provider, the hospital or doctor, and the insurance company should occur before patients are taken to court and balance billed, admits that the system understands the problem is the insurance company. The insurance company is the party that's responsible for unpaid bills, right? They're not talking about an arbitration between the hospital and the patient or between the doctor and the patient. They're talking about an arbitration between the hospital and the insurance company that's supposed to be paying the damn bill in the first place. But it's laws that are written that allow the insurance companies not to pay bills, like getting out of paying the bill through a denial process, that are the reason our healthcare system is so screwed up right now. So it's only going to make things worse if we are not able to balance bill patients. So anyway, complex issue. Did I answer the question? Yes. Did I go off on a tangent? Of course. Is it an important, relevant, salient tangent? Absolutely. Absolutely, folks. Absolutely. Do we have any more questions? No more. And nobody wanted to watch the rhizotomy. I'm so surprised. Really shocking. But life can be shocking sometimes, right? Like when you get a bill in the mail. All right. We'll be broadcasting our next Deuk laser disc repair. It's a 3-level, L34, L45, L5S1, in about 20 minutes. So come back with fresh popcorn and a hot pretzel and some nachos. It's been fun. Bye-bye.